Hey everyone, and welcome to this deep dive explainer. Today we're tackling something seriously complex, tuberculous meningitis, or TBM. We're going to walk through the entire clinical pathway step by step, making sure you get all the crucial details without needing to go bury your head in a textbook. We'll cover everything from how it first shows up to the long-term neurological outcomes. Let's get right into it. So here's our game plan for today. We'll hit 1. General info and demographics, 2. Clinical manifestations of TBM, 3. Diagnostics and CSF analysis, 4. Brain and chest imaging, 5. Treatment and corticosteroids therapy, and finally, 6. Prognosis and neurological outcomes. Let's jump in. Starting off with Section 1, General Info and Demographics. Let's look at exactly who is affected and where TBM fits into the broader global infectious disease puzzle. Now look at this number, 1%. Context is absolutely crucial here. TBM makes up just 1% of all extrapulmonary tuberculosis cases. Sounds pretty rare, right? Well, here's the paradox. Despite that tiny percentage, it is literally the most common form of central nervous system TB. And zooming out to look at all neurological infections, TBM is responsible for about 5% of all meningitis cases. But don't let that single digit fool you. This specific form of meningitis brings a notoriously high morbidity and mortality rate. It's especially devastating for folks with an HIV co-infection because their compromised immune systems just can't wall off the bacteria effectively. The demographics here are really fascinating because it paints a picture of two completely different worlds. In developing nations, this is mostly a pediatric disease, hitting young kids between 6 months and 4 years old the hardest. But flip over to the developed world and the whole demographic shifts. There, TBM is primarily an adult disease, and it's usually driven by the reactivation of a dormant TB infection, which typically happens in immunocompromised adults. We're talking about people dealing with alcoholism, diabetes, chronic steroid use, or HIV. Moving into Section 2, Clinical Manifestations of TBM. Let's trace how this illness actually progresses and builds over time in a patient. Here's the thing. TBM doesn't just kick the door down immediately. It sneaks up on you. It starts with this really deceptive prodromal phase that lasts about 2 to 3 weeks. Patients show up with super nonspecific symptoms. A low-grade fever is the most common, maybe some loss of appetite, just general malaise and fatigue. Honestly, it is so easy to misdiagnose early on. But once you hit week 3, boom, it aggressively shifts into the meningitic phase. This is where you see the severe headache, the vomiting, altered consciousness, and meningismus, which is that incredibly stiff neck caused by your body reacting to inflamed membranes. When you look closer at this severe phase, patients often show very specific focal neurological deficits. The cranial nerves take a major hit. The most common one? A cranial nerve V palsy, which messes with eye movement and causes double vision. You might also see issues with cranial nerves 3 and 4. Another massive red flag is seizures. But there's a catch. They happen in up to 50% of pediatric patients, making it a huge clinical hallmark for kids, but they're actually really uncommon in adults. All right, Section 3, Diagnostics and CSF Analysis. What's super interesting here is how the cerebrospinal fluid gives us a very specific diagnostic fingerprint. So a lumbar puncture is absolutely essential here. When we pull that CSF, we get a classic data profile. Let's break the numbers down. Cytology is going to show lymphocytic pleocytosis, basically an abnormal spike in white blood cell lymphocytes. Speaking of which, the total white blood cell count shoots way up, usually sitting between 100 and 500. You'll see the exact same jump in protein levels, also hitting that 100 to 500 range. But glucose? That drops dangerously low, plunging to less than 45 milligrams per deciliter. Oh, and the opening pressure when you do the puncture, that's characteristically elevated too. And it's not just the numbers, the fluid itself physically looks wrong. Classically, the CSF is described as yellow and opalescent. Plus, if you just leave a sample standing, it forms this distinct fibrin clot. It's a very old-school traditional hallmark, but it's a major visual clue. Now, we still have to actually isolate the organism, which used to be a total nightmare. Traditional ZN staining, super unreliable, less than 60% sensitive. And the LJ culture, which is the gold standard, takes a brutal 6 to 8 weeks to grow just because TB bacteria are incredibly slow multipliers. Patients literally do not have that kind of time. That's exactly why the WHO strongly recommends the expert MTB/RIF assay. It's an absolute game changer. It gives you 72% sensitivity, 100% specificity, and you get the results in under 2 hours. Plus, it checks for rifampin resistance at the exact same time. Moving on to Section 4, brain and chest imaging. Let's look at the radiological clues. And by the way, standard chest x-rays are actually super helpful here. They point to active or past pulmonary TB in about half of all TBM cases. But obviously, the brain is where the real damage is happening. When radiologists scan the brain, they are hunting for a very specific radiological triad. You've got basal meningeal enhancement, showing all that intense inflammation at the base of the brain, hydrocephalus, which is a really dangerous fluid buildup, and cerebral infarction, meaning brain tissue is actually dying because the blood supply is blocked. To spot that triad, we rely on two main imaging tools, but they do very different jobs. An MRI is way superior for getting into the fine details. It's fantastic for assessing cerebral infarcts, especially around the thalamus and basal ganglia, as well as cerebral edema and that meningeal enhancement. A CT scan, on the other hand, that's your emergency button. If a patient is deteriorating rapidly, a CT is the absolute fastest way to rule out life-threatening hydrocephalus that might need emergency neurosurgery. Okay, Section 5, treatment and corticosteroid therapy. Given everything we've seen, how do we actually fight this thing? Spoiler alert, it takes immediate, aggressive action. The absolute golden rule of treating TBM is right here in step 1. Do not wait for the lab results. Empiric antimicrobial therapy has to start the second you have a high clinical suspicion. Once you start, it's a marathon. Step 2 is an intense 2-month phase using a heavy 4-drug combo called HRZE. After that, step 3 is the continuation phase, where the patient stays on 2 drugs, HR, for another 7 to 10 months. You're looking at nearly a year of hardcore antibiotics. But antibiotics aren't always enough on their own. The WHO also strongly recommends adding adjunctive corticosteroids, like dexamethasone or prednisolone, and slowly tapering them over 6 to 8 weeks. Why? Because you have to calm down the host's immune system. As the bacteria die off, the body launches this massive, self-destructive inflammatory response. And if you're wondering if steroids block the antibiotics from getting into the CSF, don't worry. Studies have completely debunked that. These steroids are safe, and they absolutely save lives. Finally, Section 6, prognosis and neurological outcomes. Let's look at the aftermath, which, to be honest, is pretty sobering even when everything goes right. This stat is just brutal. The mortality rate for TBM sits anywhere from 20 to 67%. And I really want to stress this. That massive death rate exists even with the right anti-tubercular therapy given right on time. So what happens to the folks who actually survive? Well, the battle is far from over. Look at this. Only a tiny slice of treated patients, about 21.5%, make a complete neurological recovery. That means an overwhelming 78.5% of survivors have to live with incomplete recoveries or severe permanent deficits. When we say severe deficits, we're talking about massive life-altering complications. Survivors often deal with chronic hydrocephalus and catastrophic ischemic strokes. Basically, the plumbing in the brain gets blocked. They might also suffer from opticochiasmatic arachnoiditis, which is a very complex way of saying severe inflammation around the optic nerve that causes serious vision loss. We also see tuberculomas, these tumor-like masses, meningeal adhesions, lasting cranial nerve damage, and vasculitis. The aftermath is just as complex as the disease itself. So, having seen all of this, the sneaky timeline, the intense diagnostic data, and that tragically low full recovery rate, it really leaves us with something critical to ponder. Knowing that even a slight delay in diagnosis can be literally deadly, how can our global healthcare systems better standardize rapid, empiric treatments? How do we catch and defeat this thing in that sneaky prodromal phase before the severe meningitic phase even has a chance to start? Because right now, aggressive, early clinical intervention is pretty much our only shot at rewriting these tragic outcomes. Thanks so much for joining me on this explainer. I really hope walking through this pathway step by step has totally cleared up these complex concepts for you.